Hello everyone. If this is the first time you're watching our YouTube channel, let us introduce ourselves. I'm Farshad Tahmasebi, a consultant obstetrician and gynecologist. In our YouTube videos, we talk about different gynecological topics. We break them down into short videos. We go through difficult topics and repeat them in many different ways to make sure you understand. We teach you the way we have learned ourselves and strive to make you more competent practitioner. I believe if you know the reason behind every single test you request, why you interpret the test like that, and why these further investigations are needed, you can provide an excellent care for your patients. If you would like us to discuss any topics in more details and from another angle, please let us know and we provide that educational video for you. Last but not least, make sure you hit the subscribe button and turn on notification. This is the second episode of Deep Dive in CA125 series. I hope you have watched the first one, and if you have not, please go and watch it. CA125 is one of the most common gynecological tests, but there are lots of confusion regarding how to correctly interpret the results. With my colleague Wessal, we walk you through step by step about everything you should know about CA125. Let's recap before we start the next episode. Wessal, thanks for your first presentation. Can you introduce yourself to us?
So, hello everyone, my name is Wessal Yahya Hamid. I'm currently a trainee in the United Kingdom and I have a great interest in the molecule of CA125. So essentially our aim in this lecture series is to share our knowledge about this molecule so that you can have a greater understanding of how to apply it to your usual practice and also how to interpret it. So we're going to start off this lecture by giving a quick recap on the things that we covered in the previous lecture. So what is CA125? CA125 is a molecule on a very large protein called MUC16. It was initially discovered by Bass and his colleagues in 1981 as part of the work to try and develop immunotherapy for ovarian cancer. And it was initially thought to be a molecule that's specific to ovarian cancer. However, it was later discovered to be expressed in different tissues, and it also has a protective role in those tissues. So it helps provide lubrication for epithelial surfaces, and it protects against harsh insults.
I have a question. You keep saying CA125 MUC16. What is MUC?
So MUC16 and CA125 is used quite interchangeably. MUC16 essentially is a mucin, and it's a large transmembrane glycoprotein found in many epithelial surfaces. And the interesting thing about this molecule of protein is that it's heavily glycosylated, and what that means is that it contains a lot of glucose molecules, and this helps to serve its function as a lubricant in epithelial surfaces.
Oh, that's interesting, because I thought CA125, because we call it cancer antigen, is only related to ovarian cancer. But now I know that the main job of CA125, the main role is lubrication and protection from harsh insult. Maybe because of that, because of this lubricant property, you can find it in pericardium, in pleural effusion, and also in the abdominal cavity. Yes, when things need to rub against each other. Am I right?
Yes, exactly. And as I later on will explain, for example, it's also found in the eye, and it helps lubricate the eye surface, but it prevents sort of the eye tissues from sticking together. So it helps with the movement, such as blinking.
Oh, that's quite interesting. You also said something very clever last time, hybridoma. Am I right? Can you explain? Yeah. Because I was very confused when you told me how it works.
Yeah, so the hybridoma technology was what was used by Bast and his colleagues initially to develop an antibody called CA125, which was then used to recognize the CA125 antigen. The hybridoma technology essentially involved injecting mice with ovarian cancer cells, and that resulted in the mice mounting an immune response. So the B lymphocytes in these mice produce specific antibodies towards these ovarian cancer cells. And because B lymphocytes don't have the qualities of longevity and they can't mass produce antibodies, they've used those B lymphocytes and bound them to cancer cells, such as the plasmacytomas, which can mass produce antibodies. And that essentially led to a technology where they can mass produce an antibody that can be specifically used to identify the cancer antigen 125.
Okay, what I understood, correct me if I'm wrong, they use hybridoma in order to mass produce ovarian cancer antibodies. Yes?
Yes.
Okay, and also when I was going through your presentation last time, there was a couple of numbers, 888 patients, 35, 1%. I couldn't get it, properly. Can you just clarify about how can I use these numbers in order to get to the conclusion, please?
So after the development of the radioimmunoassay, it was important to establish what cutoff level that we can use to interpret when assessing patients with ovarian cancer. So what they did is they measured the levels of CA125 in 888 healthy women, and what they found is that only 1% of the women had levels above 35 units per milliliter, and this is why this new cutoff level of 35 was established.
Okay, means if the levels are less than 35, no further, for example, investigation is needed, you fall into the normal category. Am I right?
Yes.
Okay, great. Just for final recap, remember CA125 does not translate to having ovarian cancer. It depends on the age and other findings. Of course, if the patient is 65 and she's coming with loss of appetite, loss of weight, abdominal distension, and CA125 is high, you think the possibility of ovarian cancer as your first differential diagnosis, but in a woman in reproductive age, raised CA125 can be sign of severe endometriosis or even endometriosis, fibroid, heavy period, PID, all of them can raise CA125. Now I think it's time to start the second part of CA125.
So in this lecture, we will be covering CA125 and its elevation in different clinical conditions. So we've already given a brief summary about what CA125 is. So we will move on to talking about the expression of MUC16, also known as CA125, in different tissues. We will talk about its normal function, how it's raised in response to stress, CA125 in pregnancy and in the menstrual cycle, and we will also talk about it in the context of benign gynecological conditions and endometriosis.
Okay.
So MUC16 was initially thought to be expressed solely in ovarian cancer tissues. However, later on it was discovered to be expressed in the pleura, in the pericardium, and in the peritoneum. It's also expressed in the female genital reproductive tract, so it's found in the endometrium, in the endocervix, and in the fallopian tubes. It's also found in other abdominal organs, such as the pancreas, in the colon, and in the gallbladder, as well as the kidneys. And it's found in the eyes, so we find it in the conjunctiva and in the cornea.
You mean MUC16? You can find it in every tissue that you can name it. You know,
Yeah,
and
so
it's quite interesting that we think as gynecologists is only related to ovarian cancer. Okay, shall we carry on?
Yeah. So what is the primary function of CA125? Of course, a lot of research still needs to be done about this protein and its function in different tissues. But as far as we know at the moment is that it plays a key role in hydration and lubrication of tissues. It helps to form a disadhesive barrier in mucosal surfaces. So essentially what that means that it prevents pathogens from attaching themselves onto the epithelium. So essentially it plays a role in the immune defenses against pathogens. In the ocular surface, like in other epithelial surfaces, it helps provide lubrication, but also it's important in movements such as blinking by preventing the different sort of eye surfaces from sticking together. Also been found that the alteration of expression of MUC16 is associated with non-Sjogren's dry eye diseases.
Yeah, because I think if it helps lubrication and hydration, logically the alteration in expression of MUC16 or CA125 can cause dry eye. Yeah. Okay. And let's now talk about gynecology, about what's going on with MUC16 in female reproductive tract.
So in the female reproductive tract, MUC16 is expressed by endometrial tissue, specifically in glandular and epithelial cells. It's found in the female reproductive tract of a pregnant woman, and what's been found is that the MUC16 that's there can selectively bind to natural killer cells and monocytes, which are both immune cells. And this is thought to play a role in the suppression of the maternal immune response against fetal tissue. So as you can see, this plays a very important role in the fetal development. Also, there is a loss of the MUC16 expression during the receptive phase of the endometrial cycle, and this is thought to help the implantation of the blastocyst. So, as I previously explained, MUC16 normally plays a role in forming a disadhesive barrier, so it makes sense that in the receptive phase of the endometrial cycle, the loss of MUC16 will help the embryonic implantation.
If I understand correctly, during the attachment, you have got the loss of MUC16 in order to help implantation, and after that, you have got overexpression in order to modify maternal immune response to fetal tissue.
Okay, so now we will talk about how CA125 is raised in different conditions. So it's raised in both physiological and in pathological cases. So in physiological cases, there's different level of CA125 throughout pregnancy and in menstruation, and there's also variation in levels in different ages. In terms of pathological causes, we will divide these causes into benign and malignant causes. In this lecture, we won't be focusing so much on the malignant causes, as we will be talking about the other cases where we see raised CA125. Specifically, when we talk about benign causes, we'll look into the gynecological causes. So a lot of these gynecological conditions that are listed in the diagram, they cause a lot of inflammation, and we will later on explain how inflammation plays an important role in the rise of CA125.
Okay, that's interesting. You mean whatever can cause intra-abdominal inflammation, okay, they can raise CA125, am I right?
Yeah.
Okay. We want to find out more about it.
And also in the non-gynecological causes, a lot of the conditions that are listed, they cause systemic inflammation, but also conditions where we see fluid overload, such as in heart failure, liver failure, and renal failure. We also see a rise in CA125. And again, we will go on to explain why we see that. So how is CA125 raised in the context of stress? So theories suggest that CA125 is produced in response to mesothelial cells when they are under stress. And this is through two mechanisms. So there is mechanical stress and also inflammatory stress. I think it's best to look at this in the context of heart failure to try and understand this further.
Okay.
So in heart failure or congestive heart failure, there is volume overload, and that results in the stretching of mesothelial cells as what we call mechanical stress. And that, as shown in this diagram, results in increased shedding of CA125. At the same time, there's also inflammation at the local tissue level, and this inflammation results in release of inflammatory cytokines such as interleukin-1, tumour necrosis factor, and interleukin-6. So this inflammatory response results in increased synthesis of CA125, and this has also been demonstrated in vitro studies where there is an increased secretion in response to inflammatory cytokines that's been seen. In the context of ovarian cancer, the increased levels of CA125 is associated with ascites and peritoneal metastasis, again supporting this theory of the rise of CA125 in response to stress.
It's interesting because inflammatory stress can cause overexpression of CA125, and mechanical stress can cause them to shed.
Yeah.
And I think this is a combination of both that can raise CA125 in the blood. And I think this is the same for pleural effusion, for ascites, because of both mechanical and inflammatory stress. You can see raised CA125 in the blood. That's very interesting.
So now that we've discussed the rise of CA125 in response to stress, it's important that we look at it in the context of physiological changes such as pregnancy and in the menstrual cycle. So in the menstrual cycle, there is an observed fluctuation of CA125 throughout the cycle, and this fluctuation has been attributed to estrogen, and it comes from the endometrium. This has also been shown in studies where patients who've had a hysterectomy with ovarian conservation, there is no observed fluctuation in CA125. So the peak levels of CA125 are reached during menstruation, and then we observe a steady decline throughout until the end of the menstrual cycle. So there is high levels in the proliferative phase and in the early secretory phase. However, what we observe is that there is a loss of MUC16 expression in the receptive phase of the menstrual cycle, and this enables the implantation of the blastocyst.
Okay, that's great, because based on the molecular structure of MUC16, we know that they prevent attachment of foreign bodies in order to protect body from those antigens, and in order to facilitate the attachment of the blastocyte, we have to have downregulation of them. And as we have already learned, after the attachment, we have got upregulation in order to prevent the immune system or natural killer cell reject the fetus, which is quite a clever way to deal with it. And now we are going to talk about raised CA125 during pregnancy. Remember, menstrual cycle and pregnancy are two physiological processes that can cause raised CA125 and is not associated with having ovarian cancer.
So in contrast, if you look at it in the context of pregnancy, we see a rise of CA125 in the first trimester, and this has been attributed to the increased production by the decidua. The rise in CA125, as we previously mentioned, has an important role in preventing the mother's immune response from rejecting the fetal tissue. So it makes sense that we see this rise in the first trimester before the development of the placenta. We start to observe a reduction in the CA125 levels from the start of the second trimester. In terms of interpretation of the CA125 levels, it's advised that we interpret it from the second trimester onwards using the normal cutoff level of 35 units per litre, because what it's observed is that up to 35% of CA125 levels above pregnancy are actually above that level, so we should interpret it with caution. However, interestingly, in the context of preeclampsia, we see that there is a rise in the levels of CA125, especially in severe preeclampsia. At the moment, we still don't have enough data to implement this into our routine practice for screening for severe preeclampsia. However, what we can conclude from this is that this would be a response to the systemic inflammation that's observed in preeclampsia.
Oh, that's quite interesting that we have raised CA125 in the first trimester because it's coming from the placenta. We have got raised CA125 during, if someone develops severe preeclampsia, most probably due to inflammatory insult, and also during the first phase of menstrual cycle, we have got raised CA125, and during the secretory phase, we have got a downregulation of MUC16 in order to prepare the uterus if the conception has occurred to accept the fertilized egg.
Okay, so now that we've talked about the rise of CA125 in physiological conditions such as pregnancy and in the menstrual cycle, we'll move on to talk about the rise of CA125 in benign gynecological conditions. We observe a rise of CA125 in conditions such as benign ovarian cysts, tuber ovarian abscesses and pelvic inflammatory disease, in endometriosis, uterine fibroids, and in ovarian hyperstimulation syndrome. Now, the thing that all of these conditions have in common is inflammation at a local level. So it could be that the CA125 is raised in response to this inflammation. Now, if we look at more detail in the context of endometriosis, what we find is that CA125 levels is raised in response to pelvic adhesions. So it's a very good predictor for severe endometriosis. And what's been advised is that we should probably start using this very good marker in assessing patients with severe endometriosis for consideration of surgical management.
You mean in endometriosis, except from having inflammatory stress as the cause of raised CA125 because of adhesions, the mechanical stress also maybe adds on, and because of that, in severe cases we can have very raised CA125.
Yeah, so there's essentially two contributory factors that result in the raise of the CA125. So in summary, in this session we've talked about CA125, its normal function in tissues, how it's elevated in response to stress, how it's elevated in response to pregnancy and in the menstrual cycle, and also in the context of benign gynecological conditions.
I think the main message that you can take from this presentation, CA125 can raise even in physiological cases, it can raise in benign gynecological problem, it can raise in benign non-gynecological problem, and having ovarian cancer is just one of the differential diagnoses for raised CA125. Thanks for listening, and in the next lecture we are going to deep dive not only in CA125, MUC16, also we are going to have a brief discussion about MUC14, MUC4, MUC1. We are going to take you through about different glycoproteins, different functions, to get a much broader view regarding this quite amazing molecule. Thank you.
Thank you very much for watching. I hope you found this lecture useful, and stay tuned for our next videos.